morning, good afternoon, and good evening to the distinguished speakers, chairs, and the wonderful audiences of the ACNS webinars. This week has been a very sad week for us as we have lost two stalwarts of neurosurgery in this time. On behalf of the Education Committee and the President of ACNS, Professor Yoko Kato, I would like to express my deepest condolences to all the members of the ACNS on the demise of the founder and the first president, Professor Tetsuo Kano. Professor Kano was a great visionary who dedicated his life nurturing young talents throughout the world, especially in the developing countries. He was instrumental in shaping the careers of several neurosurgeons from around the world. His contributions to neurosurgery in Asia is unparalleled. We were all fortunate to have met him personally. May God give enough strength to the bereaved family to bear this irreparable loss. We pray for his soul to attain eternal peace. This week, we also saw the departure of another stellar personality in neurosurgery, Professor Sawad Bhakti. Professor Bhakti was the president of the Algerian Society of Neurosurgery. She was also a torchbearer of the Women Empowerment and chair of the Women in Neurosurgery Committee of the WFNS. The ACNS shares these griefs and express our deepest condolence to the members of her family and the Algerian Neurosurgical Society on this inconsolable loss. Coming back to our webinars, the first speaker for today is our honored guest from France, Professor Stéphane Gautanier. Professor Gautanier is the professor of neurosurgery at the Université de Paris and consultant neurosurgeon at the Hydrocephalus Clinic, Department of Neurosurgery, Hospital Bijan. Professor Gautanier has his keen interest in hydrocephalus, robotics in neurosurgery, and neuro-oncology and genomics. We are extremely honored to have him today with us for today's webinar, and he will be talking about normal pressure hydrocephalus. The second speaker for today is our honored senior faculty from Algeria, Professor Lakhdar Gouenain. Professor Gouenain is a consultant neurosurgeon at the Mustafa Pasha Hospital, Algiers, Algeria. He is also the professor at the University of Algiers. He is a member of the Society of the Chiropractic and Functional Neurosurgery of the Middle East and French-speaking Neurosurgery Society. He is a past treasurer and current general secretary of the Algerian Society of Neurosurgery. We are extremely honored to have him today as a speaker at our webinars, and today he'll be talking about deep brain stimulation in Parkinsonism. The chair for the first session of today's webinar is our honored guest from Japan, Professor Madoka Nakajima. Professor Nakajima is the professor at the Department of Neurosurgery, Juntendo University, Tokyo, Japan. Professor Nakajima is a member of the Japanese Hydrocephalus Society as well as Japan Society of Neuroendoscopy. His specialties include functional neurosurgery, epilepsy surgery, and hydrocephalus. He was the first author of the guidelines for the management of idiopathic normal pressure hydrocephalus, third edition, endorsed by the Japanese Society of Normal Pressure Hydrocephalus. We are extremely honored to have him today to chair the session of Professor Stéphane Gautanier. The second chair for today's webinar is our honored guest from Japan, Professor Yasukazu Kajita. Professor Kajita is a professor of neurosurgery at the National Hospital Organization, Nagoya Medical Center, Nagoya, Japan. Professor Kajita is an expert in the field of functional neurosurgery, and we are extremely honored to have him today for accepting our invitation to chair the second session of Professor Lakhdar Gouenain. On behalf of the Education Committee of the ACNS and the President, Professor Yoko Kato, I would like to welcome both the speakers, chairs, and the wonderful audiences to this online platform of ACNS webinars. Dr. Liu Boon Singh from Malaysia is my co-host for today. And with that introduction, I would like to hand over this platform to our first chair, Professor Nakajima.
My name is Madoka Nakajima from Juntendo University in Tokyo. Last year, we published a new guideline for the management idiopathic normal pressure hydrocephalus. So we hope that medical professionals will understand this disease and treat the increasing number of patients. So today, we invited Professor Stéphane Gautanier. So his lecture is a normal pressure hydrocephalus. So let's start his lecture.
Thank you very much. I would like to thank everybody and the organizer for inviting me to talk about hydrocephalus, which is a major concern for everyday neurosurgical practice, although poorly understood. I am not going to give all the details about normal pressure hydrocephalus, but just focus on a few key points that I think is very important for each neurosurgeon to understand. So my name is Stéphane Gautanier. I'm a professor of neurosurgery in Université de Paris and working in Hôpital Beaujon, where we have a hydrocephalus clinic dedicated to normal pressure hydrocephaly. I have conflict of interest because I have grants from Sophisa, which is a valve manufacturer. So don't listen to the valve I suggest could be the best. I am not objective with that. This is the chart we are going to follow. To start, I would like to be clear with a few definitions. Hydrocephalus is a symptomatic increase of ventricular volume associated with disturbances of CSF dynamics and associated with symptoms. To have an idea, the estimate volume of CSF within the central nervous system is about 300 millimeters. Only a very small part, 20 millimeters, are included in the ventricular system in normal adults. And the main part of CSF is lay in the subarachnoid space. We have different classification of hydrocephalus, depending on the number of ventricles that are involved, 1 to 4. Normal pressure hydrocephalus is usually 3 to 4 ventricular enlargement. The causes of, if an etiology is identified for hydrocephaly, we talk about secondary hydrocephalus, and when no cause can be identified, we talk about idiopathic hydrocephalus, which is the case with normal pressure hydrocephalus. A second very important definition is about communicating and non-communicating hydrocephalus. When there is something blocking the circulation of CSF between the ventricle and the subarachnoid space, we talk about non-communicating hydrocephalus. A very specific or very interesting radiological sign is to identify the walls of the third ventricle. Here you have a drawing of the normal walls of the third ventricle with the lamina terminalis bowing to backwards, and the floor of the third ventricle is flat. When there is a non-communicating hydrocephalus, there is a bowing of the third ventricle with an anterior bowing of the lamina terminalis, and the floor of the third ventricle is going downwards. This is a very good sign suggesting that there is a pressure gradient between the ventricular compartment and the cisterns that could be treated by third ventriculostomy, as can be seen on this picture. This is thus very important to identify this, as a first step before entering the patient in an INPH evaluation or not. Let's now talk about the pathophysiology of NPH, or of CSF circulation. What we know, everybody knows that we learned that CSF is produced by the plexus, the coroid plexus that lies in the ventricles. The secretion rate is about 21 millimeter per hour. That is about half a liter a day, quite dynamic. It then flows through the ventricles, get out the brain at the level of the foramina of Luschka and Magendie, goes in the cisterns all around the brain and the spinal cord, and the resorption is supposed to be made by arachnoid granulation along the superior sagittal sinus. A non-communicating hydrocephalus could be understood as a blockage somewhere on the CSF pathways, and communicating hydrocephalus would be a resorption problem at the level of the arachnoidal granulation. This concept is quite old. It comes from the beginning of the 20th century. Dendy showed in 1990 that surgical occlusion of a dog aqueduct, here with the small cotton ball in red, causes ventricular dilatation. You can here compare the size of ventricle in the control dog without any cotton plug here, and the dog with a cotton plug, you have a ventricular dilatation. This suggests that the occlusion of the aqueduct is able to induce a ventricular dilatation. He also showed that if you, likewise, if you do the same thing at the level of the foramen of Monro and put a piece of fascia, for example, to occlude it, you can observe a dilatation of the ventricle on the side of the foramen of Monro obliteration and no dilatation on the other side. If at the same time you remove the choroid plexus on the side where the foramen of Monro is occluded, there is no ventricular dilatation. This experiment suggests that the choroid plexus is the site of secretion of a CSF. These experiments are quite a nice way to explain communicating hydrocephalus, non-communicating hydrocephalus, but it falls short while accounting for communicating hydrocephalus. That's why another model has been developed, that is the hydrodynamic model of CSF circulation. The brain is contained in a rigid enclosure, the skull, and is subject to the pulsatility of the vascular system. Damping the pulse wave occurs in part by a rapid transfer of CSF to the spinal compartment around in the spinal canal. You can see here the cardiac pulse wave, and there the ICP pulse wave. They are synchronous, and on the ICP you have three different waves, P1, P2, P3, that reflects the cardiac activity. This can be analyzed by a Fourier transform that you can see here, where it is very easy to analyze the three cardiac component and the respiratory component also. This pulsatility is very important. When the ICP is increased, the pulsatility changes with a higher pulsatility and the change in the ratio between P1, P2, and P3 waves. Nowadays, it is possible to monitor these waves invasively while inserting an ICP monitor system, or even by transcranial Doppler, or even with MRI. These change in pulsatility are very important in the development of hydrocephalus. I'd like to show you two experiments that I think demonstrate this. This quite old experiment has been done in dogs where hydrocephalus is induced by injection of chemical in CSF in a dog. When you inject this chemical, you have a ventricular dilatation appearing quite rapidly. If you occlude here on the blue side the anterior carotid artery and then inject the chemical, you have no ventricular dilatation on the side where the carotid artery has been occluded, and a normal dilatation on the other side. So it seems that arterial pulsation are needed to induce ventricular dilatation. The last study I would like to show you is this one done in lamb, where a balloon is inserted in the lateral ventricle. In the control animal, the balloon is inserted and nothing is done. There is no ventricular dilatation. In this group of animal, a pulsatile inflation of the balloon is induced by synchronous to the cardiac cycle with an amplitude about 3 times. And even in a single administration of 8 hours, you can here see the ventricular dilatation. And there is also a chronic model where you applied a hyper dynamic pulsatility 2 hours each 2 days for about 2 to 3 weeks, and then you induce a large wide dilatation of lateral ventricle. This study suggests that hyperdynamic intraventricular pulsatility is sufficient to induce ventricular dilatation. I think this data is very important to understand that it is not only a problem with CSF circulation, but also with CSF pulsatility. And a third theory is now arising with lymphatic system, which could be impaired in hydrocephalus and explain the development of symptoms. I would like now to come closer to clinical aspects. First of all, it is important to understand that hydrocephalus is different from intracranial hypertension. Hydrocephalus has 2 different clinical syndromes. You can have acute hydrocephalus or chronic hydrocephalus. Acute hydrocephalus is the hydrocephalus which is associated with intracranial hypertension, that is to say, headache, nausea, and vomiting, and can sometimes be associated with visual impairment and papilledema on fundus. Acute hydrocephalus is an emergency, a life-threatening disease that has to be treated as soon as possible. But the vast majority of hydrocephalus is not associated with an acute syndrome, but rather with a chronic disease. There are no symptoms of intracranial hypertension, no headaches especially, but only the well-known clinical triad with gait disturbance, urinary incontinence, and cognitive dysfunction. This is very important to understand that in chronic hydrocephalus, there is no life-threatening disease and no emergency. It is a functional disease that has to be addressed with that in mind. So this is the first difference that has to be made in terms of symptoms, and it exists whatever the cause of hydrocephalus. If there is a communicating or non-communicating hydrocephalus can have the same kind of clinical symptoms. So it is not only with the clinical symptoms that you can make the difference, that is imaging that helps you to make the difference and that helps you to choose the best treatment. In emergency situation, the treatment is external ventriculostomy, but it is a temporary system that has almost no place in chronic hydrocephalus. It is something for emergency and acute hydrocephalus. Non-communicating hydrocephaly, endoscopic third ventriculostomy should always be considered first, and shunting is the treatment of communicating hydrocephalus. Last separation, I take a lot of time on that, but I think it is something very important to understand. In communicating hydrocephalus, when a cause has been identified, we talk about secondary hydrocephalus after subarachnoid hemorrhage, meningitis, trauma, tumors, whatsoever. And when no cause has been identified, we talk about idiopathic hydrocephalus, and this is where INPH stands. The definition of idiopathic normal hydrocephalus is the association of the clinical triad which has been described by Adams and Hakim in the middle of the 20th century, and enlarged ventricles. It is quite difficult to make the diagnosis because these clinical symptoms are very common in elderly people. I call it the INPH diagnosis tripod because you need these 3 legs to make a nice diagnostic of INPH. First leg, the clinical symptoms. In the trial, you have urinary incontinence. It is very important to ask the patient if he has urinary symptoms, especially urgency, because patients usually don't report spontaneously the symptoms, and they are very frequent in hydrocephalus. Almost three-quarters of patients have those symptoms. Cognitive decline is not specific of hydrocephalus. There is not a specific cognitive profile that helps to define the diagnosis. You can have memory impairment, dysexecutive syndrome. Apathy is very common in hydrocephalus. It is important to assess this cognitive decline, and they can be improved by treatment. Gait disturbance and balance disturbance are clearly the main symptoms and the most important ones, because they affect almost all patients with hydrocephalus. To define the INPH gait, I think that this study is it's an old study, but it is very interesting. It compares in red INPH patient, yellow Parkinsonism patient, and in gray normal control with the same age. You can see on this graph that the velocity of gait is decreased. This is a slow gait with small steps. The stride length is shorter than in Parkinsonism. It is a broad-based gait with a step width that is quite large, with the foot pointing outwards, and it is difficult for the patient to elevate the foot, which usually stays on the floor, and this is significantly different from Parkinsonism. So this gait is very important, and this is it reflects the main clinical circumstances when the INPH is encountered now with falls and gait disturbance in elderly people. The prevalence of INPH is not well evaluated. In Sweden, for example, a recent study showed that almost 6% of people aged 80 and older are affected by INPH, which is far more than the number of patients that are treated even in Sweden. This is the case, of course, in France. I really think that the prevalence of INPH is underestimated, and thus the disease is undertreated. Why this? Because the diagnosis of INPH is challenging. It is difficult. There are no reliable diagnostic tests. The best diagnosis option is that the patient is improved after shunting, but the decision whether shunting or not is difficult to make in old patients with comorbidities. That's one of the main reasons why people are not treated. And your role as young neurosurgeon is to change this in the future and to offer this treatment to all the maximum numbers of patients. I told you I told you before, it is very important to use clinical scales to evaluate patients at diagnosis and for follow-up, whatever the scale. There are different scales, Japanese scales or European scale, and that's the one I'm using, the European INPH scale. It is quite convenient. It gives a score for gait, neuropsychology, balance, continence, and gives a score that goes from 0 to 100. 100 is normal score for elderly people. We use this scale each time the patient is coming to the hospital, and improvement in this scale is defined as an increase of at least 5 points. This improvement, it's an easy way of understanding where the patient is and what you should do for him. The second very important leg to make the diagnosis of INPH is, of course, imaging. It is very often that imaging is the key to address patient to the neurosurgeon because it shows ventricular enlargement. So the basics of MRI is ventricular enlargement, showing that the ventriculomegaly is communicating, showing other features of INPH such as supracilian block, DESH, and it is very important also for follow-up. Ventricular enlargement is, of course, the main feature of hydrocephalus. It is quite difficult to have a reliable, easy to measure ventricular volume in daily practice. That's why most of neurosurgeons still use the Evans index that has been defined at the middle of the 20th century before the rising of MRI or CT scan, but it is easy to calculate and it is an easy way of saying that ventricles are large, but it is not a good way of following patient. The index event is the ratio of the largest diameter of the frontal horn and the largest diameter of the skull at the same level. When it is more than 0.3, it means that there is ventricular enlargement. It can vary depending on the angle of the plane you use. This picture is very important. In the following slides, I will show you many times. This is a patient who I treated a few years ago, and there is MRI before shunting and 4 years after shunting, a patient that is still very improved by a VA shunt. If we talk about ventriculomegaly, an important point is that the size of the ventricle almost has no change in INPH. Decreasing in ventricular size is seen in acute or subacute hydrocephalus, but not in INPH. If you want to reach a decrease in ventricular size, you will have complications. This is very important and very different from what you observed after subarachnoid hemorrhage or trauma. And it is very important also to tell to radiologists that always takes time to measure that. So changing in the size after treatment is not a good option. In elderly people with gait disturbance, having large ventricle doesn't mean that you have hydrocephalus. You can also have large ventricles because the volume of the brain is decreasing. I mean, brain atrophy. So you need other imaging features to make the difference between brain atrophy and hydrocephalus. One of this very important feature is the aspect of subarachnoid space. In normal pressure hydrocephalus, the sulci, especially at the high convexity and along the forks, are very narrow and almost closed. As you can see here, there is a discrepancy between the large ventricles and very narrow sulci. This picture is a T2 MRI, heavily T2, where the brain almost disappears. And you can see that here in the middle, there is no liquid. This is a picture very indicative of hydrocephalus. When you treat the patient, this is something that is improved by shunting. You can see here the very narrow sulci that open again when you treat the patient. It is sometimes difficult to make the difference with focal widening of sulci, which is also a very nice sign of hydrocephalus. And the definite difference between focal atrophy and focal widening of sulci is the decrease of this widening after treatment in INPH patients. So this is a good sign, but quite difficult to interpret, and it is subjective as the narrowing of sulci is difficult to quantify. Another sign is important. It is the dilatation of a sylvian fissure. It is also sometimes misleading because you can think that the patient has cerebral atrophy. It is in normal pressure hydrocephalus, sylvian fissure have the same behavior than ventricles, and they dilate in the same way. So this picture that used to be called suprasylvian block, that is the disappearance of CSF in the subarachnoid space above the level of a sylvian fissure, is very indicative of hydrocephalus, and it is nowadays very often called the DESH, disproportionately enlarged subarachnoid space hydrocephalus feature. It is also difficult to measure and to quantify this dilatation of the sylvian fissure, and it mainly remains a subjective evaluation, yes or not. The callosal angle is a very nice way of measuring hydrocephalus because it is reproducible and it is modified by the treatment. It is reproducible if you measure it in the right plane, and the right plane is this plane, a coronal plane going through the posterior commissure, and which is perpendicular to the anterior commissure, posterior commissure plane. You measure then the angle that draws the corpus callosum, and this angle, when it is narrow, is in favor of normal pressure hydrocephalus, and when it is large, it suggests brain atrophy. Again, it changes with shunting and has a tendency to increase while the patient is improved with the treatment. If you want to go deeper with MRI, flow MRI is a way of demonstrating that CSF is moving in the brain. It is very important to have at least non-quantitative flow MRI to demonstrate that it is a communicating hydrocephalus, as demonstrated here by T2 artifacts on MRI. It is also possible to use flow-gated MRI to quantify the movements of CSF, and an easy way of quantifying them is to calculate the velocity of CSF in the aqueduct and to measure the stroke volumes. These two data are increased in normal pressure hydrocephalus and return to normal values while the patient are shunted. It is also a way of demonstrating shunt malfunction when the values are increasing again after an initial improvement by treatment. MRI also evaluates comorbidities. Another very important thing, it is the white matter changes that are associated with hydrocephalus. We usually say that hyperintensity along periventricular white matter hyperintensity are associated with a good prognosis in hydrocephalus. This is again true in acute or subacute hydrocephalus. After subarachnoid hemorrhage, when you have this aspect, the treatment will be very efficient and you will decrease the size of the ventricle, and this hyperintensity will disappear. But this is not the case in normal pressure hydrocephalus. White matter hyperintensity are usually a mix between periventricular and deep white matter hyperintensity, and mainly reflect vascular comorbidities. These hyperintensities do not disappear while treated, but they are not contraindication to treatment. This is very important, and if you are not convinced about that, I suggest you read this very nice paper. This is, as far as I know, the only prospective randomized trial with blinded patient operated on for hydrocephalus that shows that treatment is efficient even in patients with diffuse white matter hyperintensity. So they exist, MRI can assess them, but this is not a contraindication to the surgery. Again, I think it is very important to use a scale to summarize all those data. There are two scales quite well done, I think. The DASH scale published in 17 and the RAT scale. This is the one I'm using, and it is related with the outcome of the patient. It is an easy way to explain the features of of imaging to the patient when you say you have your code, your radiological code is 8 out of 10 for hydrocephalus. It is easier than explaining all the subarachnoid space and so on and so on. Third very important leg, it is what I call hydrodynamics. Hydrodynamics is studying CSF before inserting a shunt. The simplest way, and what everybody does or almost, is the lumbar tap test. It is simple, it is widespread, it is repeatable, easy to do. The aim of a lumbar tap test is to induce the equivalent of a post-lumbar puncture syndrome. In a young patient, if you remove a lot of CSF with a big needle with a sharp end, will lead to a post-lumbar puncture syndrome with headaches and so on and so on. But in a patient which might have hydrocephalus, you are seeking to remove as much CSF as possible, and you will not have headaches, but you will have improvement as a symptom. So this is very important. I think to use a large needle with sharp end. The amount of CSF that has to be removed is there are no clear data in the literature, but it should be between 30 and 50, I think. That means that you remove a significant volume of CSF and you change the equilibrium that exists. I will use this paper from Vic also at in several slides. On this side, you see the improvement after CSF on the INPH scale. And that is to say that 5 points means improvement. And on this side, improvement on the INPH scale, 12 months after surgery. Again, 5 is the cutoff for improvement. The lumbar tap test is not something reliable to select properly the patient for surgery, because if you only operate on patients that have been improved after the tap test, here in red, you are missing a large proportion of patients that could be improved by shunting. So it is a good way, rather a good way to select patients suitable for surgery, but it is not a good way to exclude patients from treatment. Some authors try to improve this selection by using extended lumbar drainage. For example, here removing 20 millimeter H4 arrows for 4 days. It is something quite difficult. It is difficult for the patient. It is associated with complications, even in a small ratio of death. And there is a recent literature review showing that there is too little robust evidence to support the use of extended lumbar drainage for diagnosis of INPH. And this is my feeling. Different protocols of ICP recordings have been proposed to. Again, there is no wide agreement about what kind of criteria should be used: amplitude, pulsatility, compliance, B wave during sleep, during awake time, the length of recording. It is quite invasive. It necessitates intraparenchymal ICP monitoring or extensive lumbar drainage. So one should not recommend that at that time, at least for a basic diagnosis of normal pressure hydrocephalus. I think it can be very useful in patients with long-lasting valve dysfunction, especially in children in adulthood. Lumbar infusion tests are very simple. will not explain exactly how it works, but it is not more difficult than the robot tap test, but it can greatly improve the selection of patient. But again, patient with normal tap test should not be excluded from treatment of INPH. The conclusion of all that is that it is important that in your center you have a standardized way of assessing patient, and that you know the limits of the technique you use to select properly the patient and to offer the treatment to as much patient as possible. Let's now talk about the treatment of hydrocephalus. There is, to me, only one treatment, which is CSF shunting. Actually, we don't really know what we do when we insert a shunt. We could say that the aim of shunting is to improve CSF hydrodynamics, but what do we do actually? Is it removing CSF? Is it increasing CSF clearance? Is it decreasing pressure? It is decreasing pulsatility, or is it doing something else? I think that we have no clue about what we are doing. I think that acetazolamide is not a treatment of INPH. It is not efficient enough, and you lose time, and patients are losing time while using that kind of treatment. And repeated tap tests are not a treatment, again, because you should repeat them so often that it is easier to shunt patients rather than tapping them all the time. A CSF shunt is a proximal catheter which is within the central nervous system. It can be in the ventricles, it can be at the lumbar level. There is then a device that regulates the amount of CSF that is removed, and another catheter that drains CSF in a resorption area that can be peritoneum or the venous system or whatever. It doesn't matter actually. There are two types of valves. Flow-regulated valves that let always the same amount of CSF, the same volume flow of CSF, whatever the pressure, and pressure-regulated valves that let CSF flow when the intracranial pressure reaches a certain level. Most of programmable, some of these valves are programmable. That is to say that you can adjust and choose the level, the pressure level, which let the CSF flows or not. What is the best kind of valve? We have no clear evidence for that. Flow regulation, programmable, pressure regulation. We have absolutely no idea what is the best kind of valve. Should we insert a reservoir, an anti-siphon device? What is the best manufacturer? We clearly have no definite answer to those questions. What is the best kind of shunt? In pediatric patients, I think that VP shunt is better than lumbar shunts, which are associated with Chiari malformation, or with VA shunts that are associated with re-operation to lengthen the atrial catheter. But in adults, we have no evidence. Ventriculoperitoneal shunt are the most widespread because they are supposed to be easier, and the complication might be easier to handle. Ventricular atrial shunt has a nice comeback now because of ultrasonography that makes it very easy to do. It has no belly pain and probably works better than VP shunt. This is my choice, as you heard. Lumbar peritoneal shunts is mainly a question of school, but it's very interesting because it avoids having anything entering the brain. So that's one important point. I have no definite answer to give to you. What is very important is that you perfectly know the shunt and the valve you use. you should not change each time, and you should, if you want that your valve, if you want your valve to be efficient, it has to be inserted in the right place, and you have to handle it properly. The catheters should be in the correct position, and the quality of surgery is important. For example, here, a valve with blood inside. This is something linked to surgery. If you don't, if you are not very careful with each step of surgery, you clearly make the result worse. I will just expose the choice I've made and what I do. I don't pretend it to be the best, but I think it's very important to choose something and to stick to that. In Beaujon, we always insert ventricular atrial shunts in as a first line treatment. We do it under local anesthesia and sedation. We always use neuronavigation to be sure that the catheter is along the long axis of the lateral ventricle, entering by a posterior hole to have no contra-incision. This is the easiest way. And we have, I think it is very important to have all the little holes at the end of the catheter inserted in the middle of the ventricle, and to be sure that whatever the size of the ventricle, the same amount of CSF is able to flow through the shunt. We use programmable valves implanted in the highest setting, 200 millimeter of water, and then decrease steadily based on the clinical and radiological improvement. We always insert a reservoir because we use infusion tests to make the diagnosis, and it is easy to make a new infusion test in the valve if you wonder if the shunt is patent or not, and you can really have a definite response about the functioning of the shunt by this. And we use a system where everything is pre-connected, reservoir, valve, and distal catheter, to avoid any deconnection of the system. If you want to have a look at the technique, I made a few years ago a webinar with the ACNS about ventricular atrial shunting, and the link is here. Last information, it is important to have long-term follow-ups of your patient. This study, for example, in Spain, shows that when you follow your patient along the time, the good results, here in red, the rate of good result is decreasing. Of course, people are old, and their clinical status doesn't improve when they get older. And it is all the time very important during their follow-up to be able to answer, is the shunt still functioning or not? If the patient status is decreasing, it is very important to be able to answer to the neurologist, to the geriatrician, my shunt is working properly, I can do nothing more for INPH, and we should seek for other option to alleviate the symptoms of my patient. Or the shunt isn't functioning properly, and I should probably reoperate the patient. I really think it's important, and only us neurosurgeons are able to answer this question. A few take-home messages. Diagnosing of INPH is very challenging, but it is important because more than 80% of selected patients are improved by treatment. Again, comorbidities, especially cardiovascular comorbidities, are not a contraindication to shunting if your shunting technique is clean and fast. Long-term prognosis is poorly understood, that you should have standardized high-quality initial evaluation and follow-up to ensure that you give the best treatment possible to your patient. Thank you for your attention.
Thank you. Thank you, Professor Stephen Gautani. It's a nice talk. So I'm very interested. So,
Thank you.
yeah. So are there any question or comment?
Can I ask some questions?
Yes, Professor. Sure, Professor.
It's one of the wonderful educative lectures, Stefan. Wonderfully, you started addressing, you stressed on third ventricular bowing as an indicator for non-communicating hydrocephalus, how we distinguish it from communicating, and you stressed the point that for non-compressive, if third ventricle is bowed, it is you should do ETV as opposed to shunt for the other one communicating. And you told very correctly of all the symptoms of acute hydrocephalus, and importantly about your talk of idiopathic NPH. You told about 3 legs, clinical triad, hydrodynamics and imaging. Excellent lecture, but something which I want to, you also stressed very correctly, crowding of sulci at the vertex and increased CSS spaces anywhere, especially in the Sylvian area. And that is one of the hallmark, crowding of sulci at the vertex and dilatation of CSS spaces in the lower area, especially Sylvian fissure area. You also told about callosum angle, stressed the importance of that, how to distinguish it from atrophy. You also told us about velocity imaging, and also very important message you told that periventricular white matter T2 hyperintensity is not a contraindication for surgery, and you proposed that imaging score, which is very good. And also you concluded with hydrodynamics and kinds of valve, and also you told improvement rate decreases over a period of time. So follow-up is very important. Only one question. See, I have read somewhere, probably I think American Journal of Neuroradiology some time back. See, if you look at the x-axis, y-axis, and z-axis of NPH patients, frontal horn, say one of the hallmark is selective increase in z-axis. I don't know, I have read it in American Journal of Neuroradiology, which is one of the indicators for NPH. You told us about various angles, measurements, everything, but selective increase in z-axis, while x and y-axis can still remain, but the frontal horn normal. Your thoughts on this, Professor? I don't know. Am I audible?
I don't know.
Yeah. This I read somewhere. Selective increase in z-axis of the frontal horn, while x and y-axis can still remain normal. That is one of the indicators of INPH.
You mean the callosal angle at the frontal level?
Let's say you look at the X, Y, and Z measurements of frontal horn. So if you have the height is more, while AP and width of the frontal horn is still normal. If there is selective increase in the height of frontal horn, that is an indicator of high NPH. I don't. I have read somewhere, brother. Excellent.
Too, but I don't have personal experience to say if it's reliable or not.
What a great lecture, Professor. Congratulations.
Thank you.
Thank you very much. There has been the one open question which asks, how much and how quickly do you reduce the valve pressure after shunting in programmable shunt?
So I always use programmable shunt. And the first change in pressure occurs at 1 month post-operatively. I assess the patient, gait, balance, CT scan. If there is no improvement, I decrease to 150, just one step.
Now, what is the first pressure that you select?
200.
That is universal or varies with each patient?
For each patient, 200. Everybody.
Every patient, it is 200.
Yes. Okay. Especially in VA shunt, it is more efficient than in VP shunt. Okay. I always have this discussion with surgeons that are used to VP shunt. They think that 200 isn't efficient. It is not enough. It never happens that you improve patients. In our hands, about 1/3 to 1/2 of patients are improved at 200. 1/4 is improved at 150, and sometimes you have to decrease to 110. And each time I change the valve setting, I reevaluate the patient clinically and imaging 1 month later. Each time 1 month. I want to have the optimal pressure as soon as possible.
Thank you. We can ask our chair, Professor Nakajima, what is your philosophy in choosing the first pressure and how much do you reduce it at what time?
Surgery is almost the lumboperitoneal shunt. So about the lumboperitoneal shunt, we are setting the highest pressure because after surgery, sometimes CSF leakage from the puncture side because of the over drainage. The patient sometimes complain the headache. That is a high setting reason.
Thank you. Thank you very much. Yes, Dr. Ajitar wants to ask one question. Dr. Ajit.
Hello, Professor. It's a very good talk. I just want to ask regarding how often NPH is associated with the Parkinsonism. Is there any predictive measures for the prognosis of NPH after shunting if it is associated with Parkinsonism?
In older patients, it is very often associated with at least a part of Parkinsonism. When we have clinically signs of Parkinsonism, we very often do DAT scan to evaluate the dopaminergic input. Even if patients have true Parkinsonism, if there is CSF hydrodynamics abnormalities, I go for shunt. And I have experienced very different responses. Sometimes even the Parkinsonism syndrome improves with decrease in medication. Sometimes it doesn't change anything to Parkinsonism. But it is really very frequently associated. And for me, it is not a contraindication to shunting. Right.
Thank you very much. We'll take one last question from Professor Liu Gun Singh. Dr. Liu.
Yeah, thanks, Raja. Thanks, Professor, for a very interesting lecture. Professor, I just want to ask you about philosophy question. Where do you think the origin of the CSF? Do you think what you talk about pulsation? Without pulsation, there's no CSF. Do you think that it's same with other fluid, such as pleural fluid and peritoneal fluid, transudate from the capillary, but because of blood-brain barrier, the content of protein is not as other fluid. My second question, Professor, a quick one. What do you think we must do before we add normal pressure hydrocephalus? Thank you, Professor.
Did you
I
get
don't
that?
really hear you. It's difficult to understand.
There is some problem with the connection, it seems. We heard the first question.
The first question was about where does CSF arise from? This is a good question. I think that a choroid plexus is very important, but I'm quite convinced that it is not the only place. And another important issue might be that choroid plexus is not only a secretory place, it is secretion and resorption. This is a very important place of exchange, but it has to be studied. There is a wide field of investigation to do. And your second question was?
What are the minimum investigation that we need to do to label somebody as idiopathic and not secondary normal pressure hydrocephalus?
Talking to the patient and looking for history of trauma and everything. That's the first step. The MRI, the second step, and the analysis of CSF during TAP test. I think that these three arguments can classify properly patient between idiopathic or secondary.
Right.
Thank you, Professor.
Thank you very much. Yes, Professor Nakajima.
There is one question from the chat. So
Yeah. Yes, the question is, what do you do if the patient develops subdural hematoma?
It is quite rare to have subdural hematoma with a VP shunt at 200. It happens sometimes, and usually it is just something we see on the CT scan, which has no symptoms, and we just wait, and it flows away. If it is symptomatic, it is very often associated with sleep apnea syndrome, which makes huge thoracic depression during breathing efforts. And the first step is to treat the sleep apnea syndrome. If it's not enough, I change the valve and insert a valve that closes to 420 millimeters of water.
Right. Thank you very much. That's very interesting.
Most of the time, subdural hematoma appears when we decrease the opening pressure, and thus the treatment is just to increase it.
Right. Thank you very much. We can go back to our chair for his concluding remarks, Professor Nakajima. You may give your concluding remarks.
Okay. Thank you. Thank you, Steve.
Thank you very much. We have our second speaker, Professor Lakhdar Guanin, with us. Welcome, Professor. And I would like to invite Professor Yasukazu Kajita to say a short introduction and invite Professor Guanin to start his lecture. Professor Kajita.
I am Yasukazu Kajita at the Nagoya Medical Center in Japan. A lecture about DBS and the Parkinson's disease. The Parkinson's disease is characterized by the degeneration of dopaminergic neurons, and the worldwide prevalence of Parkinson's disease of 7 million and has been increasing. So Parkinson's disease is can be broadly divided the motor and non-motor symptom. So dopamine-based treatment therapy is very useful for motor symptoms. But several years later,
yes.
Yeah, so please go ahead. So we have happy to have a lecture from Professor Guanin. Yeah, please
yes.
start. Yeah, please start his lecture.
Good afternoon, everybody. First of all, I would like to thank the president of the ASEAN Congress, a neuroradiologist, a neurophysiologist, and a neuroanesthetist, and a coordinator, the neurosurgeon. The surgical procedure addresses to an idiopathic Parkinson's disease with good general health, normative and effective function, failure of drug strategy. No indication at the initial stage, the patient must have an evolution and have been MRI in. The following are the criteria of surgery exclusion: multiple medical complication, dementia, severe frontal lobe dysfunction, severe depression, no adequate drugs, programming visit, severe cerebral atrophy, significant MRI abnormalities, age more than 70 years old. Why surgery is important? L-DOPA is elective and rarely stage of disease. Within 5 to 10 years of therapy, most practice to experience complication of therapy, long period of state, improvement of the movement, dyskinesia, motor fluctuation. I would point out to you that there is early indication of Parkinson's surgery as advanced by this study by Charles and Paul in 2014. Which target? There are 3 targets are possible to stimulate orbital lesioned subthalamic nucleus, indication dyskinesia, IBS indication dyskinesia, thalamus VIM, indicator tremor, contraindication dysarthria, severe balance disturbance. About DBS in the treatment of, we performed 2 cases of pallidotomy and 2 cases of pallidal stimulation for patients with severe dyskinesia. As example, a patient with painful dyskinesia, poorly supported by himself. Most of our patients benefited from deep brain stimulation of the subthalamic nucleus in 55 cases. Effective treatment for the symptom of Parkinson's disease, tremor, rigidity, and dyskinesia. There is a good example of a patient with rigidity, freezing, and walking slowly in off. Severe dyskinesia, embarrassing, and poorly accepted by the patient in all. There has been growing enthusiasm for pedunculopontanucleus stimulation after the encouraging report of the first study, Mazon and al. At 2005, Fan and Gill 2005, Stephanie and al. 2007. However, the efficacy of this new target is elevating gait disorder has yet to be objectively demonstrated. So which surgical procedure would you practice, lesioning or deep brain stimulation? Remember that lesioning, inexpensive, fast, no programming required, irreversible unilateral treatment, and deep brain stimulation, presumably reversible, expensive, time-consuming, hardware problems, bilateral treatment. In our department, we usually proceeded MRI, head frame attached, CT scan, and finally the planning 1 day before surgery. The visible of the different target by the different technique of MRI sequence, even a few years ago by the famous Professor Ben Abid, the ventriculography. The 7 Tesla MRI to better see the VIM not visible by 1.5 Tesla. The planning, we need axial T2 MRI and coronal T2 allow us to clearly see the selected target, STN, GPR, or VIM by direct visualization. For the GPI, other sequences are used, inversion recovery and proton. MRI axial T1 allow us to choose the entrance of the electrode to avoid crossing a ventricle or a vascular structure and to verify the correct path of the definitive electrode. The surgical technique is without anti-Parkinson medication 12 hours before surgery, local anesthesia, contralateral frontal burr hole 14 millimeters, target coordinate imaging and recording in DBS, procedure lesionotomy or deep brain stimulation. We use in our department the CRW, the Cosmal Robert Wells as frame, and the Lexel frame. This patient with same electrode, local anesthesia, first stimulation with clinical monitoring, test lesion, test. We see that the tremor is off, and we do a permanent lesion without side effect during 2 minutes. Post-operative imaging of the thalamotomy, the patient before surgery, you know, the tremor, bilateral tremor. And immediately after surgery, we see the lesionotomy of right VIM and for left VIM, the right, no tremor in this side. Okay. Good result after surgery. Unilateral thalamotomy. The localization target in DBS for STN need anatomical localization imaging, electrophysiological verification by microelectrode recording, functional verification during surgery by microstimulation, and finally, electrode placement control. Several methods are used in order to have the best target coordinate. First method, formula-based ACPC and direct visualization. Lateral is plus or minus 12, right or left. Anteroposterior is -2, provided we mark the posterior border of AC and the anterior border of PC. Vertical is -4. The second method, direct visualization of STN into two axial, showing the largest mass of red nucleus, anterior and lateral boundary. STN is found 2 mm lateral and 2 mm anterior posterior, as you can clearly see in this video, in this slides. The third method, in tuto coronal, a line drawing from the midline at the level of the floor of the third ventricle to intersect with the line drawn from the thalamocaudal groove parallel to the midline. Another method, deep brain stimulation has been the surgical treatment of choice for Parkinson's disease. Create a functional lesion using electrical stimulation. The two primary targets for DBS, globus pallidus, GPI, subthalamic nucleus, and the third VIM of thalamus. Classical and visually microelectrode recording of STN, as you can see, the appearance typical of spike in the characteristic popcorn sound observed by the neurophysiologist. This image shows the descent by 5 microelectrode and macroelectrode, and there are only 3 electrodes which are in good position, on which must be tested to have the best target and without side effect. The macrostimulation done by the neurologist, which looks of the best effect of the stimulation of the rigidity, tremor, and akinesia. The neurologist gave the best results in order to replace definitive DBS lead. The neurologist will test to search the side effect of the stimulation and conclude if it is in STN or in the neighboring structure. Example, dystonia, tetanic muscles, contraction, dysarthria, if we stimulate the capsula interna. Inhibitor of L-ADOPA effect increased akinesia, substantia nigra. Diminution of tremor if we stimulate zona incerta. Correct position is to show dyskinesia or reduce of the rigidity, tremor, and the akinesia. Electrode placement control. And finally, the electrode placement is controlled by X-ray in order to observe an abnormal situation on the DBS leads. The goal is detect error of possibility incidence, follow the path of the electrode, check the position in depth, evaluate the distance to the target, means CR and ceratom in stereotactic condition. In order to reduce the surgical procedure duration, you must do MRI and surgical planning a day before surgery and the battery placement 2 days after the surgery. This will reduce the time of surgery to 4 hours instead of 6 to 7 hours. Other authors prefer to practice DBS under general anesthesia in 2 hours, but the most neurologists and neurophysiologists don't like it. Professor Marwan Hari's team in London prefer to do only a preoperative MRI and a post-operative checkup by MRI without intraoperative recording or macrostimulation properly locate the final position of the electrode. Most of neurologists and neurophysiologists do not agree with him. 3 days after surgery, The battery is implanted by subclavicular incision. The incision and the definitive leads are connected to the battery by the extension lead, beginning with Soretra, after Kenetra, Activa PC, Activa RC, Libra XP, and Infinity. Dear colleagues, the aim of DBS programming is to stimulate STN and to avoid stimulation of the neighbor's structure. Typical initial programming of DBS is 2 to 4 weeks after DBS electrode implant. Subsequent programming can be every 2 to 8 weeks for the first 3 months, and then every 3 to 6 months thereafter. Commonly takes 6 months to be the best setting. Many patients will require concurrent medication adjustment. In our experience in Mustafa Pasha Hospital, we have managed 76 patients. There is 44 men, 32 female, aged from 37 to 66 years old, with mean age of 56 years old. We have performed 2 cases of pallidotomy, 2 cases of bilateral stimulation of GPI, 70 cases of thalamotomy, and 55 cases of bilateral stimulation of STN. Thalamotomy result noted the good evolution of the epididymis after surgery for the most of the patient, which is mentioned several years later. The improvement of the epididymis was evident. For example, patient number 10, 17, 25, 27, 36, 37, 45, and 46 have almost become normal, and the reduce of the medication by 50%. Therefore, the clinical symptoms have improvement until 70%. This is the summary of the epididymis pre and post-operative. The in pre-operative goes from 59.2 to 55.3. The same of in post-operative immediately goes from 34.8 to 15.3, and from 29.7 to 15.5 after 3 years. And we note the real improvement of the state of our patients. The side resume the benefit effect of the DBS to the tremor, rigidity, and akinesia 6 months, 1 year, 3 years, and 5 years later. Some example of our patient before surgery in off. This young teacher. On medication before surgery. Like super dyskinesia with the guidance body. Immediately after surgery, 4 days after, on stimulation of medication. This is on medication, on stimulation, immediately after surgery. The same patient keep beneficial effect of the DBS 4 years later. Acceptable results. And the same 7 years later. The patient has benefited from battery replacement 7 years later, and he has kept the same benefit. And when we have the correct result, the doctor is also very happy for his patient. This woman was first operated by unilateral thalamotomy, and 2 years later had presented recurrence, and then she benefited from DBS for STM. Before surgery and off, before surgery on, and immediately after surgery. Off medication on stimulation, and here on stimulation on medication. Four years later, off medication on stimulation. On medication, on stimulation. The last example is a doctor of medication before surgery. On medication before surgery. Immediately after surgery. With his wife. And on medication, on stimulation. The same doctor, 18 months later, on stimulation of medication, on stimulation, on medication, he has started working and see his patients. I'm sorry, this is the last lady. Off medication.
Ça va, la كمليها. Faut être détendu. Très bien. Alors, dérي هكا madame Zerichi. Les deux mains comme d'habitude.
Donc, off medication.
C'est bon, Anna, je prends.
Before surgery.
Je fais madame Zerichi. Faites comme ça. Des deux côtés. Mais je joue à
On medication with severe dyskinesia.
Zédé. Très bien. Zédé. Dérي هكا madame Zerichi. Voilà.
We can see him 3 months after.
شوفي لا يحط رجلك.
On medication, on stimulation.
Balancement des bras, balancement des bras. Très bien. عاودي ولي. Oh, tu es magnifique, madame أرواحي. اوكي خذ بالشق تاعك.
Très bien, okay. Rechargeable stimulation, why? Advantage is the last longer, 9 to 25 years, less surgery, lower infection risk, per definitive end of life, they are similar. Disadvantage, they need to be recharged, require time, increase stress, remind of the disease, increased complexity, need to create recharging material, they are more expensive. Remember that DBS is symptomatic, no curative, chronic, no fatal disease. The aim is to improve life quality. Surgery should not add any new deficit to patients. In conclusion, The promising and encouraging result with the DBS modest experience support us in the well-founded of the DBS, of the subthalamic nucleus, in patients suffering from the Parkinson's disease rebelling to the medical treatment. In general, DBS seems to be a relatively safe procedure. Serious complications with permanent side effects are rare, but there are no less significant incidence of adverse effect in DBS procedure. Surgery-related and device-related complication can be reduced with increased surgical experience and the introduction of new surgical equipment and technique. Parkinson's disease surgery, which has become a current practice in most of the neurosurgical department. Thank you for your attention.
Thank you for your nice presentation. So you mentioned the important issue, including the patient selection and the targeting, and especially the surgical technique in detail. So actually the significant advancement in the management of the Parkinson's disease, but I believe that the DBS is still established the therapeutic tool for the motor complications. Yeah, so please any question or comments or something?
Yeah, Dr. Liu, would you like to ask any question?
Yeah, thanks, Raja. Prof, I just have one question regarding Parkinsonism. In your opinion, how early would the DBS be beneficial? Because you have shown that in long term, L-DOPA would not be useful. So how early you think the patient should be given treatment such as a DBS? At what age? Thank you, Professor.
The surgical treatment of Parkinson's disease by DBS, we give you a good result for 6 to 7 years after, and we must change the battery. But the medication we can reduce, in our experience, by 50%. Of the medication, and the dyskinesia is out, and the patient there is a real satisfactory by the patient in our department, and I think maybe in other departments. I work with Professor Marwan Haris, Schumann in Guyane in France, and maybe is the same result.
Right.
Thank you
very much. If there are no more questions, we can wind this up. We can get the concluding remarks from Professor Kajita.
Okay, yeah, thank you. Very nice presentations. Yeah, actually, the Parkinson's disease is a very complicated. There you stress we need to the DBS team, including the neurologist or something. But actually, DBS is a very established, the good therapeutic tool. Thank you for your lecture. Maybe your lecture is very useful or starting to the DBS in some countries. Thank you for once more.
Thank you. Thank you very much. With that, we'll conclude this webinar of today. On behalf of the Education Committee of the ACNS and the President, Professor Yoko Kato, I would like to thank both the speakers of today, Professor Stephen Gotanyai and Professor Lakhdar Goenen, for this wonderful lecture. I would also like to thank the chairs for today, Professor Mondoka Nakajima and Professor Yasukazu Kajita, for the time and support for the ACNS webinars. I would like to thank my co-host for today, Dr. Libun Singh, and a special thanks to Professor Shubin for supporting us and enabling us to reach a wider audience throughout China. Today, the total number of audiences, we have 630 neurosurgeons, and we are extremely thankful to Professor Shubin for that. So until we all meet on the 11th of August, it is bye-bye from all of us. Thank you very much for joining.